Thanks a lot for joining us this evening, and thanks for your interest. We've had a lot of interest for this evening, so it should be a very good event. My name's David Thwaites, so I'll be your host this evening, and I'll just do a few intros around the panel. Firstly, presenting first tonight, we'll have Christian Barton. So Christian is an associate professor up at La Trobe. He's the co-project lead of GLAD Australia, and also the director of Complete Sports Care, and works clinically there as well. Presenting second tonight, we'll have Nigel Hartnett. So Nigel is an orthopaedic surgeon specialising in knees and has a special interest in ligament reconstruction, total knee replacement, and complex revision total knees as well. So thanks for joining us, presenters. We also have joining us tonight Mark Morelli, or Dr. Mark Morelli. He's going to help us out with the Q&A this evening as well. So Mark is a senior lecturer and research fellow at Melbourne Uni, and he specialises in musculoskeletal physiotherapy and digital health. So without any further ado, I'll might hand over to Christian. So Christian will present tonight on Is Running Good for Your Knees? Thanks, Christian.
Thanks very much, Dave, and thanks everyone for joining us. It's really nice to have so many online. So I'm really excited to talk about this topic about running a knee away. It's a big passion of mine clinically, and also very excited to hear from Nigel. I'm going to leave a lot of the cartilage conversations and information to him, but I will touch on some things as we go through the presentation. So I'll just share my screen and bring up slides. So essentially, as Dave said, I'm going to look at whether or not we believe running is actually good for your knees, and I'll circle back to my probably biased belief that it probably is good for our knees, but hopefully I'll give you some good justification as we go along. A couple of disclosures before I start. Much of my research is funded by the NHMRC and MRFF. I do teach some courses related to running and knee injuries, and I am a director of Complete Sports Care who's hosting this event. I'm also leading a couple of not-for-profit initiatives, which some of you may be aware of, which is GLAD Australia, which is an osteoarthritis implementation project, and also an online digital translation platform called TREK, so Translating Research, Evidence and Knowledge, and I do some work for BJSM. So the plan that I'm going to go through tonight is I'm going to give you a case to set the scene, and we'll circle back to that case at the end. I'm going to talk a little bit about how do people communicate and perceive osteoarthritis and knee osteoarthritis, talk about the evidence related to running and knee joint health, evidence related to running and general health, and then I think what's really important is how do we manage the risk of someone running who might have persistent knee pain and knee osteoarthritis. And I won't be able to go into huge detail there, but I'll try and touch on a few things around principles that I tend to focus on clinically, which are both informed by evidence, but also through a lot of experience as well. So I'll introduce you to Jane. So Jane's a 37-year-old. She's a keen runner and she works in a medical field. So she's got good health literacy. She's been running for most of her life. She's got some left knee pain on and off. And this actually started around 2 years ago following a fall. She tends to cope with running okay these days until about 5 kilometers. She used to do a lot of half marathons and an occasional marathon. She's had a lot of pain recently trying to get back up to her half marathon distances. She got really intense pain for 3 or 4 days following a recent 15-kilometer run, and that's what's brought her to the clinic. She's recently tried changing her strike pattern from a rear foot to a non-rear foot strike pattern, and this didn't really help. And she got a bit of a sore calf and didn't really enjoy it all that much. Jane works in the medical field and has good access to imaging, so she's pretty easy for her to duck in and get an MRI done. And so she does this, and she finds out in short, she's got mild to moderate chondromalacia patella. She's got some menisci that don't look as healthy as we would like. She's got some clefts in her cartilage, and she's got some moderate effusion synovitis, and she's got a Baker's cyst. So all these things pointing to some early osteoarthritic changes, but equally we see this in a lot of people who don't necessarily have any knee pain as well. So Jane, being in the medical field, she consults with some of her orthopedic friends. She's offered a cortisone injection to try and settle things down. She's offered that she should probably just give up on running. She's got joint degeneration, her knees are wearing away. And a couple of people are suggesting she might want to consider an arthroscopy. So without going hugely into details on the evidence here, we know from doing knee arthroscopies in degenerative meniscal tears and also doing them in osteoarthritis and patellofemoral pain, we probably should be trialing first-line care first. So thinking about first-line management of load management and exercise and a range of other things, which we'll talk about later. Cortisone, we know, can be incredibly powerful for reducing symptoms in the short term, but may also have some harms when it comes to cartilage as well. So probably not the most useful advice to Jane, who hasn't maybe sought some other care that she could try first. So I think what this highlights really is how people typically communicate about knee osteoarthritis. I want to highlight a systematic review of qualitative research led by some colleagues that I work with. So Sam Bunsley and Nora Shields, there's surgeons and nurses and physios in this group. They actually looked at around about 62 articles and had more than 1,600 quotes from qualitative research, and included people with knee OA, carers and clinicians across 16 countries. I'm obviously not going to go into the details of the review, but in short, they identified two overarching discourses of how osteoarthritis was communicated and discussed. So impairment and participation. So impairment being that there's really not much that we can do. It's a very passive approach, doctor help me, and participation, which is, there is actually a lot of things we can do and more active management. The overarching impairment discourse prevailed in all the groups and all the study settings. So occasionally participation would be talked about, but that was very rare. And basically knee osteoarthritis was being likened to a machine that inevitably wore down over time and required a doctor to repair. So this degenerative wear and tear, bone on bone, this type of language, which really doesn't empower people to consider an exercise approach, and certainly doesn't empower people to think about running. So a colleague of mine, JF Ascoli, has been leading some really interesting research around perceptions of running and knee joint health. And one of the first studies he did a few years back was looking at a group in Canada, and he had non-runners, he had runners, and he had healthcare professionals. And he asked them a range of questions related to their beliefs around running and knee osteoarthritis and knee joint health. One of the interesting findings from this is that of those runners who didn't have any knee osteoarthritis or no diagnosis, about 80% would modify their running habits if they received that diagnosis. 57% would reduce distances, 35% would reduce speed, 27% would run less often. These may all be very sensible things to do. And about 1 in 20 suggested they would quit running altogether. This is before consulting a health professional. One of the things we often see is health professionals telling people to quit running, which is, we'll circle back to that later. Some of the other questions that they asked is, in general, I see regular running as an activity that hurts the knee. Frequent running can lead to getting knee osteoarthritis, and running longer distances can lead to getting knee osteoarthritis. So when talking to the public, then we can see some really interesting stats. So to orientate you to this graph, you'll see non-runners with OA, then you've got runners, and then you've got runners with OA. And if you look at the diagonal lines, that's the group or the response that sort of says they're uncertain about these things. And what you'll notice is that non-runners, quite a lot of them are agreeing that actually running as an activity will hurt the knee joint, and frequent running may actually lead to knee osteoarthritis. And this is much more common in those who didn't run compared to those who did run, which is interesting. So there's obviously some bias amongst runners that running may be considered safer. A greater proportion of those, I guess, non-runners certainly had negative perceptions of running. The other interesting thing is that fewer healthcare professionals agreed that regular running was detrimental for knee joint health. So that's a good sign. And this is when we're considering in people who don't have knee OA. But similar trend in terms of runners versus non-runners is that if a healthcare professional was a non-runner, they didn't run, then they're far more likely to consider that running might be detrimental to knee joint health. So it's still a decent proportion of our health professionals out there. Looking at a few other questions specifically related to those who might have knee OA, so people with osteoarthritis continue to run will sustain greater damage to their cartilage and leading to more severe OA. It's fine to keep running if you've got OA, or actually running with knee OA might actually lead to a joint replacement surgery. And so when we look at that, if the perceptions of our general public who are runners and non-runners, there's still a reasonable proportion there who believe that running would lead to greater damage. And in particular, in the non-runners, we see that not only greater damage, but if you go to graph C at the bottom there, quite a large proportion then believing that it's going to increase your chance or risk of having a knee joint replacement in the future. So there's certainly this reservation about running in the presence of knee osteoarthritis and potentially running causing knee osteoarthritis. So I've joined JF's larger team now, which is international. And so you'll see a big long list of authors from a paper we've just had accepted. And we actually did an international study across a number of studies in English, Spanish, Portuguese, Dutch. I'm trying to remember the other languages, quite a few. And we surveyed around 4,500 people from the general public. And we also had healthcare professionals as well. So we asked some very similar questions. And so what you'll see here is when we talk to the general public and healthcare professionals about their perception that, say, running might increase the risk of arthritis, running at least 3 times a week might increase the risk of arthritis, or running long distances, you'll see the more frequent or the longer the distance running, the more people believe it may be detrimental. The one I want to really highlight to you guys is the middle one, where running frequently, so at least 3 times a week, would increase the risk of getting OA. And you'll see a large proportion, more than 40% either believe that it will or aren't really sure about that question. And when we look at running things like marathons and ultra marathons, actually the majority of people in the public believe that running is going to cause knee osteoarthritis down the track. So we see more of the general public think that running is going to increase the risk of knee OA compared to healthcare professionals, which is interesting. And it probably highlights a little bit about the bias of some of our sampling, because we probably, because of our networks of people who like running and believe you can run with knee OA, we probably ended up recruiting quite a few people with similar beliefs. If we look at some other findings related to that, so going to things like joint replacement surgery, we can see again in this international cohort, following on from the data in Canada, is that actually quite a lot of the public believe that running with OA would increase the risk of having more knee pain, and around about 40% believe that if you had knee OA and you kept running, then you're going to increase your risk of TKR, and that 38% compared to about 17% of healthcare professionals. So there's a huge proportion of the population out there really having reservations about running and knee osteoarthritis. So I guess that leads us to the question, what is the truth? So a couple of key questions we can pose is regular running associated with knee OA, as a large proportion believe, or does it increase the risk of developing knee OA? And the second one is, does continuing to run with knee pain and OA increase the risk of progression and possibly surgery? So if we look to some of the evidence related to this, this is a great systematic review by Altern Galley, and they looked at this a number of years ago, doing a meta-analysis on 17 articles. They had 3 groups of runners that they synthesized, or sorry, 3 groups of people they synthesized. They had a group of what would be considered recreational runners, so they were just runners. They had a group of competitive or elite runners who specifically reported that they were professional, elite, or ex-elite athletes, or they represented their countries in international competitions. And then they had a group of people who didn't run, so non-runners. And if you just think for a second, and I always like asking my patients this, is which of those 3 groups do you believe had the highest rates of osteoarthritis? And the answer is the elite runners. So around about 13 in 100 elite runners would have had knee OA. So it's quite high, but that's not much higher than non-runners, so more sedentary people, which is around 10 out of 100. If we compare that to recreational runners at 3 out of 100, it would appear that recreational running potentially may be protective against osteoarthritis. One of the challenges we have is this is cross-sectional research, so we don't really have the prospective research to look at this, but it does sort of highlight that maybe recreational running could be a sweet spot for protecting us against osteoarthritis. So that's something that I'll often talk to patients about in the clinic, especially if they've been told to give up on running. Some other systematic review evidence, and of course I'd encourage you to read these papers if you're really, really interested, is there an association between history of running and symptomatic knee OA? And this is from the Osteoarthritis Initiative, which is a large cohort study. If you look at the numbers from this study, it's quite large. So we've got around about 1,850 non-runners and nearly 800 runners. And what they're looking at is, what do they report in terms of their history of recreational, or I guess just general running, and whether or not they've got knee pain, knee osteoarthritis, etc. And so in terms of history of leisure time running, it's not associated with any increased knee pain, not associated with any increase in radiographic OA, and not associated with any increase in symptomatic OA. So a really strong piece of evidence, again, that running's probably not going to increase our risk of developing knee osteoarthritis either radiographically or symptomatically. Remember, the catch to that is probably if you become too competitive, you may actually change that scenario. If we go to the second question, and again, just looking to some of the systematic review evidence, does continuing to run with knee pain and OA increase the risk of progression? This systematic review included 15 studies. So a lot of this is, again, retrospective research. And from this, their conclusion was, with the evidence, it really isn't possible to determine the role of running in knee OA. So it is really challenging to pinpoint whether or not running with OA increases the risk of progression. From the research, though, some of the meta-analysis in there is that actually it would suggest that there's a protective effect of running or continuing to run in the presence of OA and the need for having surgery down the track. So running may actually be protective against surgery based on the limited evidence in this review. But again, we need to really highlight that it's making sure that you're not going out crazy and getting too competitive. It's really that recreational style running. So that's something we perhaps shouldn't be telling people to give up on. So Nigel will no doubt go into much more detail about cartilage, and I'll just try and touch on it really briefly, just to give some context about how I'd often talk to patients about how we can explain these results. So if we look at the structure of articular cartilage, it's quite a complex structure. One of the most important things is it is avascular. So it relies on diffusion for nutrients. So it relies on synovial fluid, and it relies on exercise in order to do that, and particularly weight-bearing exercise, of which running is part of. If you look at the makeup of it, it has collagen fibers, and the way I talk to my patients about that is it has a sponge type structure. It has chondrocytes, which kind of help bind all that together and protect it. And within that sponge type structure, it has proteoglycans, and I often describe these to patients as salt crystals. Their job is to absorb water. So when it has a high concentration of proteoglycans within that cartilage structure or that cartilage matrix, it's able to absorb water faster and recover faster. And that's really important for being able to continue to do weight-bearing or loaded exercise like running. If we have a low concentration of proteoglycans, then the recovery is much slower. And we see a much lower concentration of proteoglycans in people who are more sedentary. So if we can load, we can increase that concentration of proteoglycans. So even in states where the cartilage may be thinner compared to what we consider as pristine cartilage, so we may have lost some of the cartilage structure, then we can still optimize the health of that cartilage really only through exercise. And when we look at imaging findings, what relates to pain, the changes in that collagen matrix and cartilage really doesn't relate to pain at all. But what we do see is that the subchondral bone, so if you look at the yellow part down here, if that's got bone bruising there, that's usually related to pain. And so what we want to do is maintain the health of this cartilage as much as possible to ensure we don't end up with bone bruising, because that's likely to lead to pain. And I'm sure Nigel will talk about surgical approaches related to that a little bit later. My really dumbed down version of that, when I talk to patients, I'll pinch a slide that we use a lot in our GLAD program that we teach the patients, and this is not just for runners, but people with OA, is that the job of the cartilage is to shock absorb and absorb load, and it needs water to do that. It has no nerves or blood supply. It's not going to be a source of pain, but it gets nourished from that synovial fluid and dynamic load. So walking and physical activity is certainly beneficial. And I would argue probably doing some running-based activities, as long as you're not doing too much, is also going to be beneficial for optimizing the health there. So if we move past the, I guess, slightly gray area of whether running causes OA, and we sort of can see pretty clearly that that's not likely the case, whether running with OA could cause problems in the future, and again, that seems unlikely. But what about the health benefits of running? So if I have a patient in my clinic and say, hey, you should give up on running, we all know that many runners who can't run will end up depressed, and the mental health side of things is a big challenge. But there's so many other things for us to consider, and one of the most important things is running is a really inexpensive and easily accessible form of moderate to vigorous physical activity. Considering the majority of the Australian population doesn't achieve this, I don't think we should be taking running away from people if we possibly can. And so why do we need to be more physically active? Well, that will help us address chronic systemic inflammation, which is going to be useful for preventing sarcopenia. It's going to be useful for reducing accumulation of fat. It's going to be useful for our brains and preventing Alzheimer's. It's going to be useful for preventing type 2 diabetes. It's going to be useful for preventing heart disease. And I could continue to go on and probably list around 35 or more chronic diseases that regular physical activity is going to be useful for, of which running is a really simple option. Now, we can tell people to try swimming, or we can tell people to try cycling, but that may be less accessible for many people, and they may not get the same benefits from it. The other thing that's important to consider, and I really like this systematic review, is thinking about running not just as a recreation, but as a lifestyle intervention, and perhaps getting more people to run is a good option for us. And if we look at mortality. And this is a really, really great review looking at that across a whole range of different populations. We can see that when we compare runners to non-runners, that runners will typically live longer. So if you look at men and women, younger and older people, even if you look at people who have a high BMI or people who smoke or people who drink, we see that running can actually extend someone's life expectancy. So we're not saying start smoking and start drinking, but certainly regardless of your underlying health profile, running seems to have some really strong benefits. And if you look at the statistics around this, you could estimate around about a 3-year increase in your life expectancy by regular running versus not running. So when I put all those things together, and I think, well, running, maybe it can be associated with pain, but so as many other things in life. Maybe it could lead to OA progression, although that appears not that likely if we're sensible about how much we do. And I weigh that up against all the benefits and the health benefits of running. I think telling someone they should give up on running is bad health advice in almost all circumstances. So I think that's a really important message I want to get across tonight. But our job as health professionals is to help them be able to do that running in a safer way and in a better way and educate them around it. So what should we do when it comes to runners with knee osteoarthritis? So I guess the first thing that we need to focus in on is trying to address that impairment discourse like we do for all musculoskeletal pain. So people get in this cycle where they have pain, they have maladaptive behaviors. So for example, in a runner, we see that they'll run with a stiffer knee. They might run and they might rotate their foot out. Now, if they're doing that, they're going to lead to hip muscle weakness, quadriceps weakness. So we see that in people with knee pain and knee osteoarthritis. Interestingly, we don't typically see hip muscle weakness in runners as a risk factor for developing knee pain, but we see it after the fact. So these maladaptive behaviors lead to deconditioning. We see physical changes, so we'll see a loss in muscle strength and muscle power, and these are things that we might need to address through exercise and rehab. There's no injection or surgery that's going to do that. There's non-physical changes, so not just the beliefs that we've been talking about, but people become sensitized to pain and develop pain sensitization. As a result of all this, we get more stress on our joints when we run, we've got less capacity, and then we're more likely to get pain. So we've got to really help people to actively get away from this impairment discourse. So one of the things that we often promote in the clinic and will promote also through programs like GLAD and things we do in our research is trying to change the message and change the narrative of knee osteoarthritis. So get people thinking about their pain related to their OA as a modifiable symptom that could be driven by many biopsychosocial factors. So to get them to understand that sleep can play a role, get them to understand that actually inactivity can play a role, that fear can play a role, that muscle weakness can play a role, that being overweight can play a role. Get them away from that bone on bone, wear and tear degeneration concept. Certainly there are some cases where that is a key component, but in the vast majority of cases, you can get well away from those structural problems. If we change that treatment focus away from the structural damage to what is modifiable, we can target things very well through exercise and lifestyle, and these are all modifiable things. And ultimately, we're putting the person in charge and giving them a positive mindset. So empowering someone to be able to get back to running or having that as a goal is a really, really strong way of doing that. It certainly motivates people a lot to do exercise, to look after their diet, a whole range of things if they've got that carrot of getting back to running. So education is really, really important part of this puzzle. If we look at ways in which we can educate, so I'll highlight an infographic which you guys can all use, and I'd encourage you to use one we published in BJSM recently, led by a master's student, James Alexander. And basically we put a series of infographics in BJSM about running, and this one in particular is related to running and knee osteoarthritis. And if we sort of go through some of the facts we've been talking about, we can see that recreational running is not harmful to knee joint articular cartilage in runners without symptomatic knee OA. We can see that participation in recreational running may provide a protective effect against the development of osteoarthritis. We do see high rates of osteoarthritis in people who are non-runners as opposed to runners, and it's important to share that information to people. It often very much conflicts with their beliefs. And then starting to think about, all right, well, what if you do have OA, what can we do? We should encourage people, they should feel safe to continue running. It doesn't appear to accelerate the progression of existing knee OA in older runners. And it's probably not sound advice for us to tell you to stop running. What we need to do is try and support you, not just with education, but also with other rehab strategies that we can apply and adopt. So this is a principle that I'll typically use, and I put an editorial in Physical Therapy in Sport a few years ago, which was a fun one to write. I'd just come off the back of reading a book called Made to Stick, so thinking about how to get your messaging right, and so acronyms, thought this is good, and managing the risk of running made lots of sense. And I think it's a really nice framework for us to consider for managing musculoskeletal pain, but it works really, really well for runners. So number one is we want to reduce overall load. And so this is the reason it's green is it's very safe. In some ways, it's very easy on paper. So it's reducing how much someone's running, how fast they're running, how frequently they're running, all those activities. But there are also some running retraining strategies we can think about, which I'll go through shortly. We want to improve someone's capacity to attenuate the load. So we can do that through strength and conditioning and getting someone in the gym, or even doing really good quality home exercise programs. And then also gradually building up their capacity over time through graded return to running programs. And then our third key option is to think about shifting load. So we can do this through changing our running technique. We can also do this through footwear, taping, a whole range of things. The reason it's in red is that actually, although it can be incredibly helpful, it can also lead to stress on other tissues and potentially cause other injuries. So we do need to be careful. And then the K from risk is to make sure that we're mindful that we need to keep adapting to the capacity of the runner. So a change that we might want to make now may not be feasible because of underlying strength, but in the future it might be. And also, what are their goals? So it's not very easy to implement a reduction in training loads and heavy strength and conditioning program with someone who's about to compete in an event in 3 or 4 weeks' time. So we need to be careful about when we bring all these things in. So if we go through some general principles, which typically work quite well from a load management education perspective, how do we reduce that overall load? One of the things that's often very helpful for runners who have got away is to minimize consecutive days. We do see in some of the literature that the recovery of the cartilage may be a little bit slower. And so that's something we can consider. And then reducing their volumes, reducing their intensity, reducing frequency in the short term, and then gradually building things up and getting them to monitor their symptoms. Not so much whether they have pain during a run, because we know that's not necessarily a very good sign that there's any tissue damage going on. It's often very hard to run without pain if you've had persistent pain, but making sure that their day-to-day symptoms settle within 24 hours after a run. If that happens, then we can be pretty comfortable and confident we're not causing any inflammatory response and causing any longer-term issues. And then from there, we gradually build up. We want to get away from this left-sided graph of boom and bust. And then I'll incorporate a lot of running retraining strategies, sometimes in the short term, sometimes in the longer term. And some people are not that familiar with running retraining. In simple terms, it's not dissimilar to trying to change your golf swing. If we go to the gym and we do strength training, that doesn't necessarily mean it's going to change the way we move and we run. Likewise, we went to the gym and did upper body strength training. It's not necessarily going to change how we hit the golf ball, and I'm a testament to that. I'd probably need some serious golf lessons. The way I would define it, and we did this a few years ago in a review where we sort of outlined some of the earlier literature related to running retraining, is we identify any theoretical mechanics which might contribute to tissue overload, establish if they can be changed. So if it's a structural reason someone runs that way, or if there's underlying strength impairments, then it may be difficult to change those things. If we can change them, then we facilitate it through encouraging motor relearning and changing the path of least resistance. So I'm not going to go into lots of theoretical concepts tonight because we don't have time, but I'm going to touch on more of the principles of what we're trying to achieve with someone with knee pain. So some of the common studies in the literature have looked at things like forefoot strike running or getting someone off their heels. So this is a really small pilot study of 8 people per group, and they retrained someone over a 2-week period. So they did 4 sessions in week 1 and 4 sessions in week 2, and they're giving cues to get them off their heels and onto their forefoot. And in that study, they had a control group who did the same thing from a running volume perspective, so reduced back to 15 minutes and gradually built back to 30 minutes, but they had no cueing in terms of their change in the running mechanics. When we look at the outcomes from this Roper study in terms of pain, you can see the control group, which is the circles. If you look at the 2-week post, there's a slight reduction in pain, probably because they're doing a little bit less running. The follow-up period was a month after that 2 weeks, and we see they regress back to where they were. The group who changed their strike pattern, they had a significant reduction in pain, and that was sustained at that 1-month follow-up. So certainly changing strike pattern can reduce persistent knee pain. And in this group was with patellofemoral pain. If we have a look at the findings a little bit further, they reported no adverse events. They did report, though, the experimental group had calf soreness. So this is something you'll see really commonly if you change strike pattern. Anyone that's had a go at doing that would know that. Suggested this resolved by 6 weeks. But 2 out of the 8 people reported medial ankle joint soreness, which was persisting at 1 month follow-up. So possibly a tib post tendon under axis strain could be a possibility. And certainly that's some of the common injuries I've seen from people changing strike pattern. So need to be a little bit cautious. We did a large systematic review on the topic of changing strike pattern a couple of years ago. We published in Sports Medicine. Some of you will have read the book Born to Run, which has inspired a lot of people to change their strike pattern and take up barefoot running because they think they're going to run faster and improve their performance and reduce their risk of injury. Without going into all the studies, because we had 53 studies that we included, essentially our key findings were that there is no evidence that would suggest that changing your strike pattern could reduce your risk of injury, and also no evidence that changing your strike pattern would improve your running economy. In fact, in the short term, it would actually reduce your running economy. So that's an important consideration. From an injury perspective, there's very little published on this other than the paper I've just mentioned. What it did show from a biomechanical sense is that if you change a strike pattern from a rear foot strike to a non-rear foot strike, so forefoot or midfoot, you will increase the load at your ankle and you will reduce it at the knee. So it may very well be therapeutic for the knee, but it may potentially be detrimental for your foot and ankle. So that's a really strong consideration that we need to think about. So if we sort of go to the clinical scenario, it can be helpful, but you really need to think carefully about, does that person have the capacity to do it? So thinking about preparation of their calf, tib post, foot musculature, you might consider footwear to try and help facilitate some of those changes too. The other common one researched in literature is step rate or cadence, and this is probably the easiest and safest way of altering joint load. So if we change somewhere between 5 and 10%, we could certainly get a reduction in knee joint loads. So typically around about a 10% increase in our step rate. So say going from 160 to 176 as an example, that might lead us to having a 15% reduction in knee joint loads. Changing strike pattern might change it by 20 or a little bit more. It's quite a simple process to do, using a metronome, using music, taking shorter, faster steps. And we certainly see in case series and other studies, we can see some sharp drops in knee pain by implementing this as part of our intervention. So it's something you can certainly trial with people in the short term. There's frontal plane options, which have been published in the literature, and typically things like opening your knees or tightening your buttocks using videos. So trying to get the runner away from this valgus position. And that can be helpful from a pain reduction perspective in the short term. Can be quite challenging if they don't have underlying muscle capacity. And there might also be structural reasons that someone runs with more knee valgus or more hip adduction that we need to consider. So they might have a femoral anteversion. And if we start trying to change that, we may shift stress somewhere else in the knee and cause other issues. So my advice to people thinking about doing running retraining is always to change sagittal plane first, and you rarely need to focus on the frontal plane mechanics. And as you go through this, you'll realize changing sagittal plane often changes frontal plane. So one of the points in this space is that in terms of gait retraining for knee pain and knee OA is that highly researched does not necessarily mean it's gold standard. So when you look at a lot of the literature, it focuses on step rate and strike pattern, a bit on shoes, which is the ones that are easy to kind of research and to do. There's a lot of other strategies we can use around proximal cueing. I'll touch on a couple of those that I commonly use in the clinic in a second. The other thing within the literature on persistent knee pain and knee OA and runners with knee OA is there really is very little evidence to support or to look at whether they're beneficial in terms of providing exercise to improve strength or power. Unfortunately, the studies that do exist are really short duration and they really don't increased load progression that would lead to any sustained improvements in strength or muscle power that are often lost in people who have got persistent knee pain and knee OA. So we can certainly have a conversation about that during question time maybe. So some of the considerations kinematically, and I'll just play a video here of someone who's got some persistent knee pain. So in the sagittal plane, we're looking at where someone's landing, and you can see in the still frame and also this runner here, they're landing a long way out in front of their body. So that's going to lead to more braking forces. And we know from biomechanical studies that increases knee joint loads. The other thing we can look at is how much knee flexion they get through mid stance, which would increase peak loading on the patellofemoral joint. Of course, we've talked about strike pattern already, but the other thing that can change where your loads go is how much hip adduction and internal rotation you get, and also thinking about pelvic drop as well. So we get a contralateral pelvic drop, which we see quite a bit of in this girl. It's going to lead to a lot more load on the lateral structures of the knee, which might irritate someone who's got PFJ OA, for example. So that's something to consider too. So what would we do from a gait retraining perspective? Our priority is not so much changing strike pattern, for example, or trying to focus on the frontal plane mechanics, but if we can try and get this girl landing under her body a little bit more, we can reduce overall load. So that's going to be an important concept. And then we may consider things like getting away from heel strike to a midfoot strike to reduce the load. So in the short term, this girl can go from a 4 or 5 out of 10 pain to being essentially pain-free, and her pain is on the left side. By if we just try and change some of these things. So just to go back over the video, we can see big valgus, big pelvic drop on the left, and we can also see the big overstride. So if I go to using a couple of simple cues, like try and take shorter, faster steps, and in this case, we get her to focus on trying to reduce her anterior pelvic tilt. We get her to tuck her bottom under, which is something that can often be really helpful for changing frontal plane alignment. And if you want to have a play while you're here, just stand up and tuck your bottom under and do a squat, stick your bottom out, do a squat, and feel what difference it makes to your mechanics. If we watch this girl here, we can see very quickly, watch her left foot strike now. She's landing with more of a forefoot strike, but she's also landing much closer under her body compared to the top one where she's landing quite heavy on her heel and extending. And if we watch what that does to her frontal plane mechanics, and I'll freeze frame this a little bit so you can really pick it up. If I can, my computer's not freeze framing it, so apologies. So there we go. And then this is with those sagittal plane changes, no focus on trying to open knees or squeeze bottom. It's really just around trying to cue her. It's not freezing. There we go. So we can see that's actually reduced her hip adduction, internal rotation, just by giving her sagittal plane cues, which has been enough to reduce her pain quite dramatically. So a couple of final videos to kind of talk you through that sagittal plane concept and how much we can reduce stress on the knee. So this is another runner here, a male this time, who we can see based on the treadmill how much it's shaking. If you watch his left foot, high toes, hitting the ground really hard on his heel. And if you watch it again, he lands with a very straight knee. If we work on him, again, we're trying to increase his step rate, trying to get a little bit less anterior pelvic tilt. Then we do that over an 8-week period, we can see some quite dramatic changes, and the amount of knee joint load he's now getting is significantly less. So if he's got some knee symptoms, which he did have, he's going to be in a much happier place running. And so the final video I want to show you of running is probably to get you think a little bit differently beyond kinematics. And I'll just pop this video up here, and I want you to just have a think to yourself if you would believe, based on what we've just been talking about, that this runner's running quietly or if he's running loudly. Based on his landing position, he lands with a soft knee, so slightly knee bent. He lands pretty soft heel strike. He's in a good pelvic position, so he's not anteriorly tilted. But if we actually have a listen to him running, he's very loud. And so this is a guy who's got really persistent anterior knee pain and early degenerative changes in his joint at a very young age. And what's important to consider here is that he hasn't done any good exercise rehab, so he doesn't have any strength or power to be able to absorb those loads related to running. So the thing I always talk to patients about is when you run, your contact time on the ground is somewhere between 0.26 and 0.32 of a second for most runners, which really only gives you about 0.1, maybe 0.15 at the most to absorb those loads. So your rate of force development of your musculature has to be really high. So getting in and doing some really good quality exercise rehab, ideally in the gym in many cases, or at least doing it at home and setting up really well with decent resistance, is really, really important. So if we circle back to Jane to finish up, this was her running at baseline. So we'll see mechanics don't look too bad. She's maybe reaching out in front of her body a little bit of anterior pelvic tilt, but it's pretty good. This was her at follow-up around 4 or 5 months later. It's probably got a little bit less anterior pelvic tilt. The upper body's a little bit more upright, and you'll see her foot's landing a little closer under a center of mass. So these are both running at around 12K an hour. In terms of mid stance, she's probably, again, at baseline, she's sort of hunched forward a little bit, sitting into her run. She probably stays upright a little bit more, but they're not big changes. Most of her improvements didn't come from any gait retraining changes, really come from doing good quality strength and conditioning work, and being really sensible about load management and gradually easing back. Frontal plane, if you can pick up any differences, please send me an email and let me know. There's really very little differences in her frontal plane mechanics, and there was certainly not a lot of role to play in that for her. She decided to go down the path of rehab and ignore the surgeon and ignore the cortisone offers and ignore the stopping running offers. And she wrote me an email. This was probably around about 12 months after we started. She's now many years after we started. She's had more issues related to her foot and plantar heel pain since this time, but you can see from her email, she's decided that perhaps going into debriding meniscus and trying to clean up the joint wasn't the best option for her. And so she's continued to run despite probably a lot of perceptions from others that she was going to cause more damage to her knee. She's been able to not only double her training volume, she's since gone back to run multiple half marathons. And I really like this quote from her that recently she pulled up a bit sore after a quick 9K, but then went out, did 18Ks the following day and seemed to fix the pain. She's also had some repeat MRIs and they don't really show any progression of her OA, and certainly her knee's in a much happier place these days, which is really nice to see. And she's getting all the health benefits of running. So you can read more about Jane on our Latrobe blog if you wanted to. She actually did a nice story on there back in 2018, and she continues to run quite prolifically, which is great. So go back to how do we manage the risk of someone with knee OA? We want to address their overstride if we can. So there's a whole range of strategies we can do, like step rate, but also proximal cueing and looking at doing strength and conditioning work, which we can maybe touch on in question time. Slowing down in the short term, reducing duration and frequency. We need to work with rehab around improving capacity to attenuate load. So quads, hamstring, calf, hip and trunk. And there's a whole range of different gait retraining strategies we can do to try and take a little bit of load away from there. Remember, we're not taking load away completely. So that's the key point to make, is that we want to keep loading the knee. We just don't want to load it excessively. And that load for running, I suspect, is probably going to be beneficial for them in the long term. And then we keep adapting to that person. So take homes before I pass it over to Nigel is, firstly, running is good for you. And as health professionals, we should do all we can to keep people running and get them back to running. Running will not cause knee OA. It's a myth. It's really important. It is a myth. Being sedentary will cause knee OA. That is not a myth. That is truth. That is very well researched. Running with knee OA is safe, and that's really important for us to remember, but our job is to make it as safe as possible, and the benefits in almost all cases are going to outweigh any harms that might be associated with it. Our job is to make sure people stay sensible and manage the risk of running if you've got knee pain and OA, and having really good guidance for somebody with exercise and rehab and cross-training and running technique and a whole range of things can make a really big difference to that. And at the end of the day, I would argue running is probably going to be good for your knees and good for your cartilage health. So a couple of websites up there, and I'll send some slides around for those who have attended, including these links. So there's a knee osteoarthritis site for patients I'd encourage you to look at, My Knee, and there's also our clinic website, which has got clinic details and some courses and different things we run. But thanks for your attention, and I'll look forward to hearing from Nigel now, unless we're going to do a couple of questions first. I'll pass that over to Dave and Mark to the side. Thanks very much.
Dave, did you want to get to them now between speakers, or you wait till the very end? Wait till the very end?
We're going to wait till the very end, yeah. So yeah, thank you very much, Christian. That was fantastic. We did get a few questions there in the Q&A, and just to highlight the Q&A function to everyone, this is how we're going to run our question and answer at the end as well. So yeah, fire away. As soon as you think of any questions for either Christian or Nigel, please write them in the Q&A tab, and we will answer a few as we go. Christian might have an opportunity to type a few answers, but don't take them all, Christian. We'll need some to ask you guys at the end. So yes, write them up as you think of them, and we'll pose them to the two presenters at the end. But thanks again, Christian. Nigel, I will hand over to you. So Nigel's presentation this evening is on when running with knee OA is a problem, what are the options? Nigel, I'll leave it over to you.
Beautiful, thank you. Good evening, everyone, and thank you for giving up your Wednesday evening to come and listen to Christian and myself. Thank you very much, Christian, for an excellent talk. There is going to be a little bit of overlap from what I speak about and what Christian has spoken about as well. And for those of you who do not know me, my name's Nigel. I'm a knee surgeon in Melbourne, and Tonight, we are going to speak about the implications of running with knee OA and from a surgical perspective. So the aims from my point of view are basically to gain an understanding on the presentation and pathology of knee arthritis, to learn the implications that running has on knees that have arthritis, and also to gain a knowledge of the non-surgical and surgical considerations for those people that do run with arthritis. And for those of you who do know me, I'm very non-surgically focused, and I like to use surgery as a last resort. Now, arthritis as a disease is actually a disease of multifactorial origin. It basically leads to joint surface degeneration and the clinical symptoms that we get with that. What causes it? Generally speaking, aging, wear and tear. Genetics is a factor in about 1 in 5 people. And so the younger that you see someone with arthritis, the more likely they are to have a genetic component in the absence of injury or trauma. Trauma, previous surgery, infection do play a role in the development of secondary arthritis. And obesity, interestingly enough, we think obesity causes arthritis, but the jury is actually still out on that at the moment. So normal articular cartilage has the ability to withstand high levels of load, and it does that by distributing or dissipating the load across the joint surface. And what that does is it minimizes focal peak stresses of the articular cartilage and the subchondral bone. And as we all know, when it is damaged, damage is irreversible. There's really no coming back from it, and the joint surface does not heal easily. And Christian gave a very nice synopsis of cartilage anatomy, and so that's going to save me a couple of minutes here. But essentially, there are a number of zones of the joint surface. When we're doing arthroscopy, we generally see the superficial zone, which is the zone that undergoes, unfortunately, the first stage of, shall we say, degeneration or damage. But it undergoes degeneration and damage because the other zones deeper to it are actually sending up chemical mediators for that, unless there is some form of injury or trauma to that superficial zone. And as Christian said, articular cartilage is avascular. It gets its nutrition through diffusion, not through vascular supply through the subchondral bone. And it's also aneural as well for the most part. And so when people have pain, they're getting pain, generally speaking, through the subchondral plate, because the nerve and pain receptors are located just under the plate. So basically in the cancellous bone or at and around that subchondral bone before it goes into the tide mark. In terms of the actual process of arthritis development, this is a lovely diagram from Siebel, on the left showing a healthy joint and on the right showing established OA. Now, not wanting to get too technical here, but unfortunately, what happens is that the chondrocytes located in those superficial zones, they, unfortunately, through repetitive loading or stress, and there's a number of hypotheses that have been developed looking at how degeneration occurs, but we're just going to talk about repetitive loading and stress because that's what running is, causes, unfortunately, to be a release of chemical mediators, of which TNF alpha, the interleukins, and the MMPs are highly, shall we say, regulated. That when stress occurs, they are released. They then have a consequent effect of affecting the tide mark or the subchondral bone. And the consequent effect of that is that they're releasing growth factors that cause extra bone to be grown, hence why we get osteophytes, which are bone spurs at the edges of the joint. Arthritis, when you're having a look at x-rays, you'll see these osteophytes at the edges, whereas in rheumatoid or inflammatory arthritis, you'll generally tend to get central osteophytes. And as this process progresses, the level of TNF alpha increases, and then you get more specific interleukins, which are interleukin 1, you get insulin-like growth factor 1 and TGF beta involved, and then that leads to apoptosis, and then the joint surface does degenerate. But joint surface degeneration is not just related to the joint. There is a disturbance of mechanical function, and as we get older, unfortunately, our meniscal cartilages do tend to degenerate. And as Christian said, unfortunately, what happens is there's a change in the water content, there's a change in the proteoglycan content, and there's a change in the GAG content as well. This can also be and develop from ligament dysfunction. So we all know that if we rupture our ACL, we are likely at some stage to develop arthritis. It can also develop from abnormal joint anatomy, and that is particularly seen in people that have patellofemoral instability, and when they get patellofemoral osteoarthrosis in their 40s or 50s. Malalignment is also a very important cause of osteoarthritis development and instability developing. Obviously, joint injury previously, joint surgery do increase your chances, and as mentioned, genetic predisposition also has a role. We all know that the symptoms of OA are pain, swelling. There's mechanical symptoms, there's stiffness, there's decreased movement. The knee may be unstable, it may have a feeling of locking or jamming or catching. And generally speaking, people have inactivity type symptoms. So you ask them, do you wake up overnight? Or first thing in the morning, how does your knee feel? Or if you have been sitting for a while and you go to stand up, how does your knee feel? Arthritis loves being inactive. Arthritis does not like activity. So people will be stiff and sore when they first get moving, but then that pain that and that stiffness they've been experiencing will settle. In terms of imaging, I'm just going to touch very briefly on this. X-rays are important, but unfortunately these days there's virtually an MRI scanner in every suburb. So all the patients I generally see will have had an MRI scan before they've actually called my rooms. And what we're looking for on an MRI scan is a couple of things. Now, I'm demonstrating in these scans the difference between osteoarthritis and joint surface damage. So to have osteoarthritis, you need to have damage on both sides of the joint. To have joint surface damage, that just needs to occur on one side. So arthritis, technically speaking, is damage on the femur and the tibia, or damage on the femur and the patella. Pre-arthritis, which I term that condition, is just damage to one side of the joint. And Christian was talking about subchondral marrow edema, which are these light areas here, and this little sliver of grey hair. They can be subtle at times. And from my point of view, when I'm treating pre-arthritic knees, I also like to get cartilage mapping, which assigns a colour to a grey scale. So with the MRI scans, there are 256 shades of grey. But with the algorithm that has been developed, we can assign a colour scale to determine the activity of that joint surface. Even though it may look normal on the MRI scan, we do know that joint surface health can be a lot different in the cartilage mapping that is undertaken. In terms of grading arthritis, look, orthopedic surgeons can't think in sort of classifications more than 3. So it is a bit odd that we have a classification of 4. This is a Calgren-Lawrence system. 0 and 1 are essentially normal. Grade 2 is where the joint space is narrowing, but there are no osteophytes. And that's the big distinction between 2 and 3. In 3, we're getting little osteophytes forming. And grade 4, complete loss of joint space. And grade 4 is the best rated in terms of inter and intra-observer variability for orthopedic surgeons, doctors, and radiologists in terms of grading. The other grades, the sensitivity of these 2 grades is a little bit more fluctuant. But the important thing, and one of the big take-home points from my talk tonight, is please do not treat the x-rays or the imaging. Treat the patient who is in front of you, because you have to individualize treatment for the patient in front of you. If I treated every single person that came in with bone-on-bone arthritis, I would be doing 800 knee joint replacements a year. As it is, I do just under 200. And those patients that we do not do knee replacement on, even though they're bone on bone, there are really good non-surgical management strategies in place that those patients can employ where surgery is not required. We also have to remember that we're not only focusing on the knee, and as Christian said, there are psychosocial and psychological factors that come into play as well, and we have to treat their headspace and mental well-being. We all know that exercise is really important. As we get older though, exercise becomes more important. As we get older, the chance of developing arthritis becomes greater. So one of the questions that is trying to be answered at the moment is regular physical activity leading to the development of arthritis, or is regular physical activity actually protective against arthritis? And I'll go more for the latter than the former. We do know that participation in particularly level 1 sports, which are the cutting, twisting, turning sports that are prevalent in Melbourne, there is more chance of joint surface degeneration and an increased chance of arthritis. Going to the other end of the spectrum, we know that unfortunately children and teenagers who present with knee pain are going to develop arthritis in the future. Even if we do not see anything on the imaging, there will be microscopic changes to the articular surface. We do know as they get older, their quality of life will be poorer. We also are looking at early sports specialisation to actually see if training in one sport may lead to overuse and the consequent potential risk of increased knee injury. Now, I'm a numbers person, so before we get into sort of the running component, it's estimated that 1 in 4 people in America by 2040 will have osteoarthrosis. As Christian has said, 10% of the population who have osteoarthrosis are sedentary. And it's estimated by 2030 that 4 million people a year in America will be having knee joint replacement. In Australia, the rate of knee joint replacement has increased by just over 200% from 2000 to 2021. And the cost of the American economy over 7 years is nearly $500 billion. As Christian has alluded, elite athletes are actually more likely to develop arthritis compared with age, gender, height, and weight controls. We also know, though, that if you are playing a level 1 sport or any sport that requires repetitive loading, that there may be a chance of an increase in arthritis. But when you actually stop that sport, the risk of arthritis actually lessens. However, it has been shown that in soccer players, those that stop playing 5 to 15 years after they've stopped playing, 50% of them will actually show X-ray features of arthritis. And again, this is really important. Don't treat the X-ray, treat the patient. In America, 56 million people jog or run each year, which is about 1 in 6 of the American population. Runner's knee, which is a very loose collection of terms for anterior knee problems, occur in 23% of the running population. And runner's knee actually accounts for 17% of musculoskeletal primary care visits in America. A study done looking at running a follow-up of 15 years, just on 115,000 people, and Christian alluded to this in his talk, 3.5% of those patients, recreational runners with OA, and 13% were elite runners. Marathon runners, interestingly, diagnosis rate of arthritis at 46.8 years does not mean treatment was instituted, it just means the diagnosis was made. And 1 in 4 marathon runners over the age of 65 have arthritis. Running distance, the jury's still out a little bit on this, but it has been shown that if you run 40 kilometers a day, your weight-bearing joint surface will show some damage with MRI scan at 1 year. Interestingly, if you are a marathon runner, you had less of a chance of developing arthritis if you're training 58 kilometers a week versus non-marathon runners who are doing less than that. Irrespective of whether you run or not, 3% of runners will get arthritis, and up to 80% of runners at some stage in their career will develop a running injury. When we consider running and arthritis, we have to divide into 2 categories, intrinsic factors and extrinsic factors. So intrinsic factors, Christian has alluded to. is basically around the joint. The muscle forces going through the joint, the lower limb. Extrinsic factors are things that we can modify and basically relate how we run, how we train, and the fuel going in. Bastic did an excellent systematic review of the progression of knee arthritis in runners and found there's no association with gender, quad strength, knee pain, severity, regular sports activity, or knee injury. They did find an increased association with the progression of knee arthritis in patients who had Heberdin's nodes, which are the little bumpy bits on the end of your fingers, or sorry, on your interphalangeal joints. Baseline knee pain, if you were varus and if in your synovial fluid, you had an increase in tumor necrosis factor alpha or hyaluronic acid. Interestingly, they did find an inverse relationship with vitamin D. So if you took vitamin D, your progression of OA lessened, and there was no consensus in this systematic review on BMI. Christian spoke about the study by Alan Torngeli and found no association with running distance, intensity, duration, marathons completed, knee pain, or X-ray progression. If we have a look at running versus no running, the studies do show that there's really not a lot of difference at the end of the day. One study did attempt to quantify how much is too much, and they found that 92 kilometers a week was sort of the tipping point for developing arthritis versus not developing arthritis. In one study, they actually found that if you did not run, you were actually 20% more likely to have knee pain than runners. And animal studies, primarily in rats and rodents, have actually shown that if you start running at some point, rather than being a lifelong runner, you're actually more likely to have joint surface degeneration. But that's hard to extrapolate into humans. Christian also touched on this study by Ho, looking at people over the age of 50. So these people are starting to get joint surface degeneration. Their synovial fluid makeup is starting to change. And they found that runners had improved knee pain. They did not have a worsening of knee pain if they had knee pain, and there was no X-ray progression. Again, Christian touched on this study by Timmins, and they found no difference in runners for OA rates, disability scores, or imaging findings. And as Christian said, there was a almost 50% reduced odds ratio of undergoing surgery because of OA. In the normal joint, again, as Christian has alluded to, we have up to 8 times our body weight going through running, but running compared with walking, there's a shorter duration of ground contact and a long stride length, but running also improves the biofeedback and physiologic loops going on around the joint in terms of muscle mass, strength, body weight maintenance, proprioception, and limb compliance. And all comes back to neural feedback loops, physiologic loops, and the whole biofeedback mechanism. When we look at arthrokinematics, and this was a lovely study that actually sort of changed my perspective of what I tell patients in terms of running with arthritis. And they actually found that in patients in both the medial and lateral compartments, that during the gait cycle, you had higher contact pressures when walking compared with running. And that was statistically significant in both the medial and lateral compartment in terms of contact area, particularly not on foot strike, but as you were just coming into flexion. And so putting this into a modeling algorithm, this is the tibia, this is the femur. The blue is walking, the red is running. And what they found is with walking, you had a greater surface area of contact, which was more centralized, whereas with running on both the femur and tibia, the contact area was shorter and was more posterior, which is important in the development and progression of arthritis, particularly on foot strike. The adductor moment is a little bit controversial because there's conflicting research, and as Christian very eloquently alluded to in his talk, now it's not just the knee that you have to worry about. It is your hip, it is your pelvis, your lumbar spine, and your foot. as well. When we look at joint cartilage effect and running and walking, it does not matter what you do, the joint cartilage volume and or depth will decrease with any activity, but it will rebound or respawn once you have stopped that activity. And in an interesting study done by Simon, running 1 mile increased the water and proteoglycan content, and that is good because that is a protective mechanism. And the consequent effect of running is it increases your periarticular ligament hypertrophy, which again feeds back in proprioception, feeds back into that biofeedback neural feedback loop, and you get muscle adaptive hypertrophy, which again is important for joint health. Bucock across the ditch in New Zealand, and for some of you, you may know I'm a New Zealander, did a very eloquent study looking at people that run between 30 to 40 kilometres on average 2 to 3 times a week. They got them to run in the lab for 18 minutes and then did an MRI scan at 1 p.m. And they found that there was a deformation decrease in joint surface of around 4 to 6%, depending on which area they were looking at. Kirsten investigated the effect of running 60 minutes on a joint surface and found that all joint surfaces were deformed. So patellofemoral joint, tibiofemoral joints between 2.6 and 3.2%. They were using a hypothetical computer model, and they could not account for this change in volume on the basis of joint force and torque, and did think, well, maybe it is the adductor moment that is causing this change in volume. As Christian has alluded to, and some of the questions in the first part of the talk that Christian gave, low, moderate volume running, I do believe is protective because it increases the good things in the synovial fluid, and that synovial fluid then feeds through nutrition into the articular cartilage. High volume running has been shown on the MRI scan. If you're running more than 40 kilometers a day, you'll get subchondral bone change. Proteoglycan concentration decreases, cartilage indentation stiffness decreases as well. And that will have permanent effects on the joint surface after a year. Someone did ask about the patellofemoral joint in terms of treating that versus the tibiofemoral joint in the Q&A, and they're very different, incredibly different at the end of the day. How we treat patellofemoral joint should not be the same as how we treat the tibiofemoral joint. Remember, the patella is a sesamoid. It increases the lever arm of the quadriceps through range of movement, but the patella is always in contact with the trochlea at some point of the extension flexion cycle. And because of that constant contact, which is moving up and down dependent on where you are in that extension flexion cycle, patellofemoral complaints in runners are the most common problems seen. And treating those, as I say, are different to the tibiofemoral compartment. Now, Heckelman did perhaps the most eloquent study I'm going to speak about tonight, where they got people at 7 a.m., lay down for 45 minutes, wheelchaired them to the MRI scanner, then got them to do a 3 or 10 mile run, then wheelchaired them back to the MRI scanner to do a post-run MRI scan. Then the next morning brought them at 7 a.m., laid them down again, and then wheelchaired them to their MRI scan and did a recovery MRI scan. And what they found was with the patella, there was a statistically significant difference pre-run and post-run, irrespective of how far you ran. The difference was greater, though, if you ran 10 miles versus 3 miles. They found no difference in trochlear cartilage thickness. Panush has shown that if you run greater than 44 kilometers a week compared with non-runners, there's no difference in symptoms or X-ray findings. Son, in comparing runners with swimmers, actually found swimmers had more problems with OA and were more likely to undergo surgery, and that's statistically significant. Just 6 studies to finish off. Conradson, Lane and Chakravarti, age-matched controls, really found no difference in terms of X-ray difference arthritis progression. But what they did find is if you did run, your bone mineral density was greater than non-runners. Kahatsu, Thielen, and Hootman looked at age match controls with those people who did run or participated in sports compared with control subjects, and they found no association with running, but they did find an association with cutting sports in terms of presence of arthritis. And Kahatsu showed that actually twice as many control subjects had arthritis progression than runners did. Hootman showed no association with running and arthritis, but did find a progression with BMI, older age, and previous trauma. So some of you may be scratching your head and going, well, Nigel's just given us a whole lot of conflicting information there about running versus not running. And the simple answer is, yes, I have, because when you are researching a topic or when you're trying to find an answer to something, there are inherent biases in place, and you can get from the literature what you want. So the purpose of that, before I get into treatment, was just to demonstrate that there are a lot of studies that show a lot of different things at the end of the day. Now, in terms of treatment, for me, I use a stairway of a treatment. So I start off with really basic, non-invasive stuff, and I work my way up, the last step being surgery. And this is how we should treat people with OA and running. So pain medication, anti-inflammatories, use Panadol, Panadol-Osteo, and an anti-inflammatory 60 to 90 minutes before the run. It does work. It's good for moderate and severe pain in the short term. In the medium and longer term, is probably better for those patients who have a milder level of arthritis than a more severe level of arthritis. Using anti-inflammatories with those people that have blood pressure does create an increased risk of heart attack, only if you're on an anti-inflammatory for more than 2 months. Stopping and starting, having one every couple of days is not going to increase your risk. The original joint supplement, glucosamine and chondroitin, did show a good response up until around about 6 months, but then from 6 months onwards, it's no better than placebo. Curcumin has been shown to actually have an effect on TNF-alpha and some of the interleukins and some of the MMPs. It does have anti-inflammatory properties as well, and about 60% of the patients I see in the rooms do get some benefit from it. Always tell people with joint supplements, give it a 6-week trial. Joint supplements cannot be used on people with blood thinners because of the interaction in the liver. Physiotherapy, look, not just because I'm talking to predominantly physiotherapists, but physiotherapy is really important. And for those physios who know myself, will understand that I'm very pro physiotherapy. And as Christian said, any form of physical rehabilitation will improve your function and quality of life. And it has been shown that 3 months of physio and exercise will decrease symptoms, will improve other system areas in the body, will decrease your BMI, and will actually lead to a generally improved quality of life. Injections are very controversial because yes, they do work, and no, they do not work. It really depends on the individual. At the end of the day, I do not use steroid if I can help it. Steroid injections can affect chondrocyte health. And so if you have more than 2 steroid injections in a calendar 12 months, the effect on chondrocyte health can deteriorate, and you can soften the cartilage, which can lead to more joint surface deterioration. PRP has gained a bit of press in Australia recently. There have been 2 randomised controlled trials released, one from Tasmania, one from the University of Melbourne, showing that PRP injections do not work compared with control. There are definitely some Americans who got up in arms about that because the size of the PRP being injected is relatively small in Australia. In America, they aim generally for 30-60 mils of PRP, whereas in Australia it's 5 to 15, and there is a dose-dependent treatment cutoff. And so we may not be injecting enough PRP into our knees in Australia. Hyaluronic acid does work. I only inject it for people with grade 3 arthritis. So they're the people that have decreased joint space with osteophytes. And that will generally buy them 9 to 12 months. Stem cells, jury's still out, works well for focal defects around 1 centimetre, but for widespread arthritis, it is really expensive. And in my opinion, as I say, the jury's not quite there yet. Genicular nerves, for those of you who don't know, are specifically pain nerves that come out of the bone in very specific areas on the femur and the tibia. And all they do is supply pain sensation. They've got no cutaneous function. They've got no knee joint range of movement function. They have no muscle function. It's a curse and a blessing for me. The blessing is we have these nerves so I can operate. The curse is that for patients, if these nerves did not exist, they would not have knee pain. And so I use genicular nerve treatment specifically for people who are too young or too old for knee replacement, or those that just do not want a knee replacement. And that does work well for around 9 to 12 months, providing between a 50 and 90% pain reduction in about 70% of patients. Rocker shoes, Christian spoke about hindfoot strike versus midfoot and forefoot strike, and it has been shown that rocker shoes does decrease the amount of work being done by the knee by alterating foot mechanics. And Kerrigan looked at American shoe runners versus Kenyan barefoot runners, and found that barefoot runners actually had less arthritis type symptoms, and their running style created less load through the knee. But as Christian has mentioned, there is an increase in ankle joint load. In terms of orthotics, Yasuda showed that if you use an insole with an anti-inflammatory, that's much better than just using an anti-inflammatory alone. Using a wedged insole creates a calcaneal shift, which gives them a more vertical mechanical axis, which I'm going to talk about very shortly. And Fernandez, in his meta-analysis, showed that anyone who used an orthotic, be it ankle or knee, had improvement in their knee symptoms. But the problem with using a knee orthosis is that compliance decreases with time. However, he did show if you did not use an orthotic, that your pain response over a 12-month period was a lot more variable, as opposed to wearing orthotic where the pain response was a lot more stable. Now, surgery. So this is the last resort, in my opinion. And so what determines whether I do an osteotomy versus a unicompartmental knee replacement or a knee replacement? And it comes generally down to 5 factors: patient age, weight, morphotype, so basically them compared with their peers, ligament status, and stage of arthritis. Patient activity level and occupation also comes into it, but that's more in the morphotype category. Osteotomy versus knee replacement. Generally speaking, osteotomy is a joint preservation procedure versus knee replacement, which is an artificial joint procedure. Osteotomy allows greater freedom than knee replacement, and partial knee replacement allows greater freedom than total knee replacement. And what I mean by that is you can do more with an osteotomy than you can do with a partial knee, than you can do with a knee replacement. And it has been shown that osteotomy patients, and to a lesser degree, partial knee patients, are more motivated to return to sports than total knee joint replacement patients are. So in my opinion, arthroscopy for arthritis is not an option. And that's why that line is moving. You should not see any patient having an arthroscopy for arthritic symptoms. It's a big no-no. The research has been there for over 2 decades now. Surgical options include osteotomy, partial knee replacement, so only replacing the arthritic part, or total knee joint replacement. Now, total knee joint replacement is where you replace the whole knee. Knee joint replacement is where you just replace the tibiofemoral compartments. Just before I get into the arthritis surgery options, just talking about pre-arthritis. So this is where you have damage to one side of the joint surface, there are options in play. Chondroplasty, which is where we're just debriding the joint surface. Microfracture, which is where we're putting holes into the joint surface to stimulate a scar cartilage response. And then there is what we call Oates procedures. So we're taking plugs of joint surface either from the patient or from a donor and putting them back into those damaged areas, or autologous chondrocyte implantation, which does not have a Medicare number in Australia anymore. So these options are really good to consider for people that have pre-arthritis. In terms of osteotomy, be it femoral or tibial, it's a realignment surgery for malalignment. We're doing it for deformity or angular deformity within the joint or within the femur and or the tibia, or we're doing it for the joint and the femur and or the tibia. And what it does is change the mechanical axis. It redistributes the weight-bearing force away from the damaged joint into the non-damaged joint. It's a joint preservation procedure. It's an excellent surgical procedure, in my opinion, for those under the age of 60. There are a lot of orthopedic surgeons that do not believe in osteotomy, and there are a number of knee surgeons who do not offer osteotomy or even partial knee replacement. And that's a philosophy issue, which I have no issue or concern with. But for myself, I offer the full gambit of surgery around the knee to try and give the patient the best possible result to get them back to what they want to do. So, distal femoral osteotomy. So this basically is where we are creating from a single saw cut a triangle. This is a 44-year-old patient who has presented with valgus or lateral compartment knee OA, secondary to a tibial plateau fracture. The metal wear was removed, the plateau has collapsed. They have presented with a knock-knee deformity. This line is called the mechanical axis. It's drawn from the center of the hip to the center of the ankle. Where that line passes through in the knee is where the forces are going through that particular part of the knee. And in osteotomy, what we're trying to do is we're trying to shift the load from the affected joint into the non-affected joint. And for lateral compartment OA, we do femoral osteotomy. Generally speaking, we can at times, if the degree of correction is small, look at the tibia, but I like femoral osteotomy, and we create a wedge. So by making a single saw cut and opening up the outside part of the femur, we're shifting the ankle center towards the inside part. And this is what it looks like. So we've shifted that line from here to here by creating a wedge of bone in the femur. We could take a wedge of bone out from the inside part of the femur, but there's a lot of clockwork on the inside part of the knee, not so much clockwork on the outside part of the knee. Likewise with high tibial osteotomy, which is generally done for medial compartment OA, we're trying to take the weight-bearing axis towards the lateral compartment. And we do that by creating a wedge of bone again and shifting the mechanical axis, the blue-green line, towards the lateral compartment. In high tibial osteotomy, we're not trying to shift it straight into the center. We are trying to shift it a little bit further towards the outside. Most humans will take weight and load through the medial tibial eminence. Some cultural groups and ethnic groups will take a lot more weight through the medial compartment. Osteotomy rehabilitation, the most important thing is protected weight bearing for the first 6 weeks, full weight bearing at 6 weeks, and then into open chain exercises, resistance training, and weights activities. At 12 weeks, I do not allow my patients to run or play sports, but we increase their activity. At 6 months, depending on an X-ray findings, clinical examination, I then allow them to do a graduated return to running and sports. By that I mean, for running interval training, going down to local park, picking a soccer pitch or a footy oval, using the lines run, walk, increasing running distance as they get more comfortable. Sarah Gaglia showed that in their series, 71% of patients were motivated to return to pre-surgery activities This versus 13% of patients with total knee. And they had a high rate of return of runners following HTO and also double osteotomy surgery. 80% of patients were satisfied with the surgery, which is about the same for knee replacement in Australia. But the main reason people did not return was because of pain. Now, Positelio in femoral osteotomy found that of their 10 patients, 7 returned to running. Average return to sport was just on 17 months. There was no breakdown of their particular sporting activity, but that did range from 6 months up to 3 years. Reasons for not returning generally are pain and fear, and that's virtually for any knee surgery. The surgeon recommendation at 30% is pretty high, and 1 in 10 people did not want or have any interest in returning to their activity. Now, knee replacement, there are generally 3 different forms of knee replacement: kneecap or patellofemoral joint replacement. This is most common in females between the age of 40 to 60 with unrecognized patellofemoral instability. Partial knee, just replacing the part of the knee that is arthritic, or full knee joint replacement. Or, which is replacing, all of the compartments of the knee, or knee joint replacement, just replacing the tibiofemoral compartment. For me, to do knee replacement, it's done when all surgical options have been undertaken, their quality of life is on the floor, their pain is through the roof. Knee joint replacement surgery, pretty standard rehabilitation protocol. Weight bearing is tolerated right from the get-go, which is different to osteotomy, which is protected in my hands. Return to work activities and leisure activities between 6 and 12 weeks. Then return to activities as comfortable. I've asterisked sports activities because Kirster did show in a lovely study in 2000 looking at gait mechanics and knee replacement. They found that the forces going through the knee replacement were actually quite high in the beginning of flexion cycles, except for cyclists, which are at 80 to 90 degrees of flexion, which is basically the push down on the pedal, the pull up on the pedal. The problem with running with knee replacement is polyethylene delamination or cracking. There is a case study in the literature where a marathon runner at 35 kilometers had a catastrophic failure of his knee replacement, where the actual polyethylene, so that's the bit of plastic that sits in between the 2 metal compartments, has actually cracked and dislodged from the tibial component. Cement cracking can be an issue, but it's pretty rare. Loosening of the knee joint replacement can occur, and subchondral marrow edema through increased stress between the cement bone interface can also occur. There's no consensus. The factors involved, generally speaking, it's the surgeon and their philosophy. Patient factors, operative factors do come into play, the type of implant used, and whether the implant is cemented or uncemented, or a combination of cement versus and no cement. The evidence or lack of it is pretty poor, it's sparse, low quality evidence, it's speculative, anecdotal, and there is a huge surgeon bias involved. In terms of meta-analyses looking at return to physical activity after uni or total knee joint replacement, the take-home points were patient expectations need to be dealt with. If indicated, patients should have a partial knee over a total. Patients should not actually take up a sports activity they have not participated in after they've had a knee replacement. Patients should consider recreational activity over endurance activity. And their return to sports activities were really, really quick, which I do disagree with. In terms of running and knee replacement, 6 studies looking at runners, and they found, generally speaking, 1 to 10% of patients in their series could return to running, irrespective of knee replacement type. Richoy looked at 3 ultramarathon runners doing an 80-kilometer run in the French Alps with an altitude gradient of 2,000 meters. And they found that, 3 of the 2,500 patients they sampled had knee replacements. So conclusions from my point of view: exercise is important in any stage of life. Running has important health benefits, and having arthritis is not a contraindication for not running. Treat the patient, not the imaging. Running seems to be protective against arthritis. running distance may be a factor in cartilage degeneration. Running seems to reduce risk of requiring surgery. Non-surgical treatment options for arthritis are essential before considering surgery. And that case study that Christian presented was absolutely fantastic. And in my hands, I would have gone and said to that patient, go and do all of the non-surgical things first before considering an operation. Even in the presence of a meniscal tear, if there are no mechanical symptoms, or even if there are mechanical symptoms, go through the non-surgical stuff first. Surgery is a last resort, osteotomy over partial knee versus total knee. You can run following surgery, but lower the patient expectations. Thank you very much for listening. Thank you, David and Christian, for inviting me along tonight.
Thank you very much, Nigel. Fantastic presentation, and covered a lot, and I think hopefully stimulate a little bit of discussion here as well. So again, everyone, I'll get you to type in your questions if you can. We'll start to pose a few now to both Christian and Nigel. So I might lead off, unless you've got one ready to go, Mark. I did see one there just previously on the cartilage grading, Nigel. Yeah.
So if you have an MRI scanner, you can, generally speaking, use a colour algorithm, but I, generally speaking, use very specific centres for that. So in Melbourne, I use Imaging Associates in Box Hill, Paul Marks and Chris Holden. In Sydney, I use James Linklater at Castlereagh Imaging. In other parts of the country, I'm more than happy to provide details for those places. And as I say, cartilage mapping is really dependent on the MRI centre doing it, so that's why I use specific places.
Is it part of a standard medical imaging program, or do you need to sort of purchase or access it separately?
It is a separate medical imaging program, but as I say, all of the, all of the imaging centres will have access to that.
Fantastic.
So thanks, Dave. Thanks, Nigel. The question we had was about Celebrex dosage, Nigel. So patient who's on 100 milligrams of Celebrex twice a day in terms of recommendations around continuing long term.
Yeah, so Celebrex is a little bit odd at the moment. It depends on who you speak to. Some people are just advocating taking Celebrex once a day, and definitely immediately post-surgery, that's what we are doing. We're going to 200 milligrams once a day. You can divide the dose up into 100 milligrams BD. I wouldn't recommend taking Celebrex on a regular basis because of gastrointestinal side effects that can happen. And I'm generally, with anti-inflammatories, I'm a little bit more reactive rather than proactive. And what I mean by that is I actually get patients to actually take an anti-inflammatory before they do an activity, rather than just keeping on taking the anti-inflammatory long-term at the end of the day. So from my point of view, yeah, if you're going to be on long-term Celebrex, you're probably going to a slightly higher dose, but once a day. But I would, as I say, I tend to use it more on a PRN basis.
So Nigel, I'm going to just take a couple of quick fire questions and then I'm going to ask you a question which relates to a question that someone else has asked. So a couple of brief ones from people. So someone asking about treadmill running versus overground running in terms of retraining. It's an important consideration. So just in short, the main consideration difference is that a treadmill will do a lot of your hip extensor work for you. So we don't see big differences in mechanics between treadmill and overground running until we get to higher speeds. When we get to higher speeds, what a treadmill will often do is hide any deficits in strength and power through your hip and hamstrings, etc. So in terms of cues you'll use for running and training, won't really change all that much. They'll often be a lot easier to implement with proximal cues on the treadmill. So my advice practically is to, if someone runs overground, try and get them overground at some point early on in the rehab phase. But at the beginning, it's often easier with a treadmill. A question from Rowena about specific S&C principles to use. I think one of the important things often in this population is to ensure that when you're doing rehab that you're addressing muscles that you want to address. So for example, you might want to target lower abdominal musculature and gluteal muscles, and you try to do loading exercises like deadlifts, or you might be doing things like squats and those sorts of activities, and they'll just load up through their knee, for example, or they'll just load up through their back. So probably targeting things in more isolation initially can be really helpful if they've got impairments, and then working through a process of getting some loading, whether that be isometric or slow concentric, slowly loading up heavier and heavier, working towards strength, and then eventually I think doing some rate of force development. And once you've got decent capacity through the whole chain, very valuable to do some low volume plyometric exercises. So you can get away with doing some counter movement jumps, counter movement hops, hopping, skipping with really low volume sets of maybe 8 or 10. It's very unlikely to flare them up, but it will give those tissues a stimulus for rehabbing them. So that's quite helpful. There was another question about, so I've lost it now. So there's another question about lifestyle and what's our best bang for buck. So there's lots of things we can talk to patients about with OA around lifestyle. My advice is to present and have a really long conversation with them about all the potential things that might be contributed to their pain and their symptoms. So talk to them about diet, talk to them about sleep, talk to them about maybe stress and food and those types of things. There may be hormonal factors in some populations. So you may have a perimenopausal female. You may have someone who is really just doing too much running. Talk to them about all those different factors. And then from there, they end up with a smorgasbord of options they can start to try. And so you find one that they're willing to behavior change at that point in time, make some changes with that, and then reassure them that if that's not meeting their needs, there's lots more options for them to slowly work through over time. And they can be the easiest to list. I'll jump over to a question for Nigel and myself that was asked about returning someone to running following a joint replacement surgery, which I think is a really interesting one. I'll go through some biomechanical principles I'd work on with somebody. I'll always talk to the surgeon first. I'm going to throw it to Nigel first. What's your guidance if someone's desperate to go back to running and you've done a joint replacement surgery with them? What do you tell them?
Look, at the end of the day, it all comes down to the patient. And I really have no issue with them returning to running, but I would actually like them to do, as I said, go through an interval training type exercise first on a soft surface. So generally speaking, grass, and see how they feel, because that is going to actually guide them in terms of whether they can actually get back to running as a recreational activity. Because if they don't go well with that, they're not going to go well, full stop. So from my point of view, no real issues, but I just get them to do interval training, short distances, soft surface, see how they go.
Cool. Yeah. So that sounds great. From a mechanical sense, the things I'd encourage you to look at, do a running assessment with them and have a look at how they're landing. If you're trying to protect a tibiofemoral joint, so a new joint, you really don't want them landing with a straight knee, landing a long way out in front of their body. It's going to lead to a lot of shearing forces on that joint. So ensuring that they can land with some knee bend. So making sure they've got hamstring capacity to do that, making sure they've quadriceps capacity to do that and take some load through there. And ensuring you really get the knee in a very happy place so they can actually take some load through their muscle structures, as opposed to the joint is often something I'd really focus in on. And exactly what Nigel said, so interval training and probably just having a conversation with them. Don't go out running marathons, but we know the benefits of running for lots of other reasons. So let's get you being able to do a little bit and doing it maybe a few times a week and not trying to use it as your main and only source of aerobic exercise.
So I'll just answer a few rapid fire ones that have come through specifically for me. So Lucas asked about cartilage restoration techniques and delaying progression of OA. Yes, they do work, and they do, generally speaking, prevent the progression of OA and therefore the need for further surgery. Thorleen did ask about alignment and load management when they have particularly marked malalignment. Again, it just comes back to the patient at the end of the day. If they want to run, I really don't have any issues. In terms of running, Christian will be able to speak more about sort of the mechanics of gross varus or valgus malalignment. Darren has asked about running, increasing subchondral cysts. look, there's a little bit of evidence to say that increased loading through the joint in the presence of subchondral cyst will make the subchondral cyst bigger. But there's also some evidence saying that because you're running, you're increasing your bone mineral density. So those cysts will not actually get bigger. And so again, conflicting research there. Graham has asked about robot-assisted surgery. Does it deliver better outcomes for patients in general surgery? Simple answer to it, no. Duncan has asked about imaging. Can you effectively treat symptomatic and potentially avoid any catastrophizing with the report? Absolutely. You know, that is a huge thing, because some patients will get hold of their report and will come to clinic, and, you know, I'll list, you know, I'll go through everything, and they'll go, yeah, but I've got 7 things wrong with me. You know, the 2 things you haven't mentioned. And so some patients get really hung up on reports at the end of the day. So I just will tell you people as a group, yeah, if you can avoid getting imaging, then there's no real point at the end of the day. If you really want to get an image, get an X-ray, because you can't really catastrophize on an X-ray. Brody has asked about meniscal tears. And look, from my point of view, meniscal tears, there's only one tear pattern that I will routinely offer surgery to, and that's bucket handle tears, because they cause locking of the knee. Any other tear pattern depends on whether they have mechanical symptoms or not. I will generally get all of my patients to have physiotherapy. And so from that point of view, it just depends on how they progress with physio. So not all tear patterns require surgery, only in the presence of mechanical symptoms. If they're young, absence of arthritis, grade 3 or 4, no surgery. Grade 2, yes, you can look at doing so. Lana's asked a question about severe knee valgus and pain-free patients. It's a lovely question, Lana, because people with valgus knee OA actually present with pain as a late symptom. So I will tend to operate on people with valgus knee OA if they have increasing deformity or instability in the absence of pain. I will operate on people that have valgus or lateral compartment knee, excuse me, OA, if they do have pain. So to put it simply, if they have lateral compartment OA and their deformity is increasing beyond 10 degrees, and if they have instability, then doing a knee replacement is a good thing to do. Wagisha, sorry if I've got your name incorrect in pronunciation, has asked about total hip joint replacement. Yes, you can get loosening with with hip joint replacement. And cement cracking, I'm not too sure on. I haven't done a hip replacement for 7 odd years now, so I can't actually give you any up-to-date information on that. Lana's asked another question on the necessity of surgery for post-lateral corner of injury. Depends on the injury. Lateral collateral ligament, popliteus tears generally will need surgery if they're in combination. If there's just a sprain, brace and get them going. Someone did ask a question about why I would consider pain management before physiotherapy. To qualify my statement, I actually use physiotherapy as a first line. Pain management is my first line treatment is physiotherapy, pain management of required and joint supplementation. So all 3 things of those are basically one step at the end of the day. Prior Caitlin's asked about knee replacement. Why do we often hear that patients are too young? Yeah, they do wear out over time. In Australia, at 10 years, knee joint replacements going well 95.8% of the time. At 20 years, knee joint replacements, depending on the kind of knee replacement, between 80 and 85% are going well. The younger you are, the more likely you are to need to have a knee joint replacement. I think that's enough talking from my point of view.
Done well there, Nigel.
Rapid fire. A couple for you there, Christian. Maybe a couple of short ones. Hamstring versus quadriceps strengthening more important for managing long-term risk?
Yeah, look, I think I don't think you can place importance on one over the other. If we think about the function of them both, they do slightly different things with running. So your quadriceps are going to be really important for absorbing load through the early phase of impact. So they need to attenuate a lot of force. if you don't have good quadriceps function, you're not going to get good attenuation through your knee. You're going to get a lot more shearing stresses through your tibiofemoral joint. And typically, if you've got poor quadriceps function, you're going to end up with worse deterioration of strength through your medial quads, and that'll typically lead to more patellofemoral issues. The hamstring perspective, if you really have poor hamstring muscle function and capacity, that'll typically lead you to having challenges of trying to land closer on your center of mass. So you're typically going to have that more overstride pattern, especially if you try and run faster. And you're going to hit the ground with a lot heavier impacts as well. So having hamstring muscle power is going to be important. Arguably, hamstring is going to be really important for performance. So those runners who are trying to get back to running faster, unless you really rehab that side of things, then you're going to have a lot of challenges with that. So I don't think you want to separate them. I think they're equally important, and you'd be probably pretty foolish to only rehab one of them or only focus on rehab on one. In terms of how you do that, which is obviously the next question, I think you really need to go to open chain for both if you can. So leg extension, and if you've got patellofemoral issues, a couple of little tips is start isometrically. Make sure you go into external hip rotation, which will typically be more comfortable. Target the medial quads a little bit more. Stay away from terminal extension because that'll stop you from irritating the fat pad. If you need to, you can go to things like blood flow restriction. It's quite helpful. For the hamstrings, you can certainly do things like a long lever bridge, so foot up on a chair or foot up on a step. But if you really want to get at isolating that hamstring muscle, you often need to go into more of a leg curl type movement, and ideally leg curl machine. But if you don't have access to that, you can use heavy bands and other ways of setting up resistance at home.
Very good.
Another one. We also had a
go for it. Yeah.
I was going to say we had a question about air track and anti-gravity treadmill for deloading. Thoughts?
Yeah, so I've used them a little bit in the past. When I was in London many years ago, we had one in the clinic where I worked, and they were very helpful for stress fractures and for getting people back from bone stress injuries. They're very helpful for making people realize what would happen if they lost 20 kilos and how they might feel when they got running around and doing things. From a knee perspective, if someone's got some bone edema, sometimes they can be part of that process of getting them back and returning to running in more elite settings. I found them to be useful in club settings where they've got those. But the vast majority of people with knee OA, if they're needing to run on an anti-gravity treadmill, we really need to have a careful think about why that is. And it really probably comes down to them not managing loads properly and doing load management and doing the rehab and all the other things that they need to do. So it's probably more from an elite setting perspective you might consider them. The other thing is the cost of it too. They're pretty expensive to buy and service and manage or hire access to.
Nigel, I just had a quick one. You spoke just a little bit before about you're talking about valgus deformity. Is there I suppose, a cutoff in terms of, I suppose, the amount of degree of valgus deformity? Does it start to become difficult and more challenging to manage surgically once they go past a certain point?
Oh, look, most definitely. At the end of the day, it's in terms of determining when someone gets a knee joint replacement with a valgus deformity. That's something that we again really have no consensus on. We do know that with lateral compartment OA that you do get increasing deformity. And so when people start to notice an increasing deformity, or definitely when they're starting to notice increased instability, that is when I will tell them they need to consider having a knee replacement. The more deformity there is, the more technically challenging, because the problem is the lateral collateral ligament, because it goes from your femur to your fibula rather than from femur to tibia. When that shortens up, that's really hard to lengthen out. Whereas with an MCL, if that shortens up, that's really easy to lengthen out at the end of the day. And again, the lateral collateral ligament is it's a cord-like structure, whereas the MCL is basically sort of a flat structure at the end of the day. So from my point of view, yeah, look, yesterday, for example, I had a lady who was 19 degrees valgus, severe hindfoot valgus, midfoot collapse, external rotation of her foot in relation to a tibia of nearly 30 degrees, with severe internal tibial rotation, so a miserable malalignment. And yeah, I had to put in a slightly different knee replacement to what I normally do, extensive lateral releases, ITB, popliteus, lateral collateral ligament was pie crusted, lateral retinaculum was really tight, so we had to do Z-plasty on that as well. So, as I say, yeah, lateral compartment OA is a different kettle of fish to medial compartment OA.
Good. Mark, do you have one ready to go?
I was going to say both Nigel and Christian did talk about shoes a little bit before, but whether there is a question in here about footwear, so I might pose it to Christian in the first instance. Any specific footwear recommendations, Christian?
I was just starting to type back to and answer one of those about varying footwear and varying type. So I guess if we focus on the word vary for a second, the variation of different types of shoes we know might reduce our injury risk slightly, and that can be helpful for some people with persistent knee pain is varying shoes. In terms of trying to prescribe a shoe based on foot type, we really don't have any evidence that that can be done well. And the challenge is, how do you define a foot type? If you look at it statically and structurally, that really doesn't necessarily replicate what's happening dynamically. The other thing, if you play around with gait retraining, which we do a lot of at the clinic, is you'll realize that changing something at the hip or the pelvis or giving cues proximally will completely change what your foot does, and therefore will change what shoe may be best for you. So my usual advice for people with shoes is to try and find something that feels comfortable, something that is lightweight, and something that facilitates them, going back to those sagittal plane mechanics, facilitates it so it's easier to land closer under their center of mass and easier to control what their trunk's doing. And so I'll usually send them to a shoe store to play around with a few different shoes. Typically, if we're talking about persistent knee pain and knee OA, that will usually not just be a lighter shoe, but often a shoe that's got a lower stack height. So not just the pitch of the shoe, which is the difference between the heel and the forefoot, but the whole thickness of the shoe. Because the thicker the shoe is, the more likely you are to land out in front of your center of mass. It's going to hit earlier. So trying to find a shoe with a little bit lower stack height. The caveat to that is, though, if we start minimalizing how much support we have with the shoe and someone's used to having lots of support, that may set them up for more stress around their foot and ankle. And we then start to maybe increase their risk of stress fractures, Achilles issues, a whole range of other things too. So it's a bit of trial and error. So that's a long answer, complicated question, but in short, comfortable, lightweight, makes it easier to run without overstriding. That's my tendency to focus.
That's great. So that is comprehensive as you can get. Fantastic. Nigel, did you have anything you want to add to that? Any further thoughts?
No.
No, beautiful.
Taking care of that.
It was so comprehensive. That's good. Quick one here. I think you did speak to this, I think, a little bit in your presentation, Nigel, but were there any sort of thoughts on, best short-term strategies to help with runners with sort of large performance-orientated goals? So I think the question mark here was around sort of injections. So perhaps marathon or ultra marathon runners without sort of the risk of maybe some long-term change.
Look, we all know of AFL players who are basically getting injected every week with something into their knee to basically get them through the game and the season. And it's the same with marathon runners at the end of the day. If they are doing a marathon, if they want to do the marathon, and if they have an effusion, then putting in one corticosteroid injection is not going to break the bank at the end of the day, and it will enable them to complete the marathon. The question after that, though, is we can't keep on doing that if they want to keep on running. So we have to find better strategies to help them out. Things like hyaluronic acid, PRP, and stem cell are not going to be the quick fix for runners. Those injections are going to give a more graduated, medium to longer term sort of solution at the end of the day. But these people are better off, as Christian again has eloquently described, is maybe looking at running and gait mechanics, looking at, muscle power, looking at, differences between hamstrings and quads, and just maybe looking at footwear as well. I don't think, in my opinion, that offering repeated injections is the way to go, and that, there should be other management strategies put in place.
Excellent. Now, I am just looking at the clock. So I might call last question. Did either Mark or Christian, did you have anything you wanted to ask or answer before we wrap things up?
There's so many good questions, Dave. I'm always passionate about education and how to provide that, but I'll leave it to you to decide the last question.
Why don't we go with like a final pearl of wisdom or something, Dave? I don't know. Summarize your 1 hour talks each into one sentence or something.
I'll take a question rather than us talking around in circles. So there's a question from James about how, and I think I'll get the question right of the intent of it. How differently do you explain knee away? So rather than wear and tear or bone on bone. And I think this is a really important thing for us to consider. So what we need to describe knee away is as a whole person issue. So pain and symptoms have impacts from both physical things and non-physical things. So we know there's a poor relationship between pain and damage, and Nigel very well articulated that and gave so many great studies around that in relation to running. And so we need to have people understand all the different modifiable factors that could maybe make them more sensitive to pain, increase their pain intensity. So sleep, diet, a whole range of things like that. And also the different structures in the knee. It's not likely to be the cartilage that we see, that we refer to as bone on bone and wear and tear, that's likely to drive their symptoms. They will be pretty consistent, those imaging findings, but their symptoms will go up and down. It'll be to do with irritation of structures like the fat pad. It'll be irritation of the synovium. It'll be synovitis in the joint because the joint's being loaded too much of what it can do. And if we understand that, these are all things that can be modified by reducing loading, being more sensible about loading, getting stronger, sleeping better, eating better. And if we can change the narrative around how we describe why people have pain and symptoms related to arthritis, I think it goes a long way to steering them down appropriate active management pathways.
I think that's a very good one to end on. Some really good messages there. So I just want to thank both presenters today. Both spoke very well, I think, on a really interesting topic. We did get a lot of interest in this particular event. So I think it's, is something that everyone's quite interested in. So thank you very much for putting your presentations together today. And thank you also to Mark Moroli for helping out with some of the questions there at the end. This is the third sort of free webinar event we've run probably in the last 6 months. So we may look to do another one of these before the end of the year, I think. So keep your ear to the ground. We'll definitely be advertising another one probably before the end of the year. And I think that will do. So thank you all again.
Dave just mentioned it will be uploaded to the YouTube channel. Did you want to?
Oh yeah. So we have recorded this evening. So those of you, we'll email out the information to that once it's up. But it will be uploaded to our YouTube channel. So those of you that do need to view it again or pass on to those that couldn't make it, it will be uploaded probably within the week. Thanks, guys. I will let you all log off, and we will hopefully see you again soon.
Thank you.
Thank you. Thanks so much for joining us, Nigel. Thanks for organising, Dave and Mark.
Thank you.